Good morning. Welcome, everyone. Are you ready? Thank you so much for joining us today. My name is Dr. Phyllis Hayes, and I am the Assistant Vice Chancellor for External Engagement here at UI Health. Welcome to our beautiful campus, the University of Illinois, Chicago. This is my co-chair. I'm going to let her introduce herself, and then we'll open with the video. Thank you.
Hello, everyone. Thank you so much for being here. I'm Emily Cooper. I'm the VP of Programs at the Chicagoland Chamber of Commerce. Really thrilled to be here with all of you today, and thank you so much, Dr. Hayes.
All right.
Greetings and good morning. My name is Dr. Bob Barish, and I'm UIC's Vice Chancellor for Health Affairs. It is my pleasure to welcome the National Kidney Foundation of Illinois to UIC's campus today during your 2023 Leadership Summit. This outstanding group of scientific researchers and providers convened today will explore the current landscape of disparities in chronic kidney disease in Illinois and how to improve the diagnosis and management of the disease, especially in communities who experience it more acutely. As UIC's academic health enterprise, UI Health is committed to the pursuit of health equity. Through the integration of a clinical delivery system with the academic, training, and research program of UIC's 7 health sciences colleges, UI Health takes a comprehensive approach to treating both the medical conditions of patients, but also the structural social determinants of health that influence the health and wellness of our neighborhoods and communities. UI Health provides comprehensive care, education, and research to the people of Illinois and beyond. A part of the University of Illinois Chicago, UIC, UI Health comprises a clinical enterprise and includes a tertiary care hospital, over 40 outpatient care locations, and a network of 13 federally qualified mile-square health center locations. Last year, UI Health launched the Specialty Care Building. This new building accommodates the growth in outpatient surgery cases and provides comprehensive outpatient care for UI Health's patients. Most notably, the UI Health Kidney Transplant Program, which serves the most diverse patient population in the region, features a fully Spanish-speaking kidney transplant team. Indeed, every element of this building aims to provide exceptional patient and family experience while also enhancing comprehensive outpatient care. UIC is proud to host the NKFI's Ending Disparities in Chronic Kidney Disease Summit, as it pairs directly with our forward-thinking approach to address inequalities in healthcare to better meet patients in need across the state. Today, as you hear discussions among the distinguished leaders on the agenda, you will no doubt be inspired by the broad spectrum of topics and innovative approaches presented. Indeed, it is an honor to host these important conversations to transform our systemic approach to the burden of chronic kidney disease in Illinois and beyond. So once again, I'd like to thank everyone for spending time today to deepen your knowledge and understanding of modern issues in chronic kidney disease and our mutual pursuit of health equity. Thank you and enjoy the remainder of today's summit.
Well, thank you, Dr. Barish. That's my boss. So before we get started, I'd like to just do a few housekeeping rules and give a shout out to the folks online. Thank you for joining us virtually, and we hope that we don't experience any technical problems. If we do, let us know. But listen, I want to make sure that our cell phones are muted. Make sure that you know the restrooms in this building. There's one to our right and one to the left. And we shall carry on with the program, and hopefully everything will go okay, and we will. And Ms. Jackie, thank you so much on behalf of Emily and I. Thank you for having us as the co-host today, and Ms. Monica. So listen, we'll carry on. We have a script. Jackie and Monica, I know that there's some VIPs in the room, and if there's someone you guys need us to give a shout out to, please let us know who they are. But I shall carry on and we'll get started. We have the PowerPoint ready? Yeah, can't see behind me, so good. All right, so I want to thank Dr. Barish for that wonderful video and welcome you all to the Ending Disparities in Kidney Disease Illinois Leadership Summit, of which I understand, and I've been working with these ladies for about 4 months. This is our first time doing it in Illinois. So let's give ourselves a round of applause. Yes, yes. As I mentioned, I'm the Assistant Vice Chancellor for External Engagement here at UIC, and I work in the community. My background, I've been an educator in this, I'm gonna tell you how old I am. I've been an educator in the Chicagoland area since I was 21. I just made 68. It's time for me to sit down, you all. But there's so much to do. I began my teaching career as a special education teacher with Chicago Public Schools in 1978. I have a passion for improved educational systems, which include access, diversity, inclusion, healthcare, human development, healthcare improvement for communities of color, economic empowerment, which is really, really crucial to our communities, along with focusing on the rights of the working class citizens and the underserved. Myself today, for me, my personal goal for this summit is to educate and empower our communities on the importance of developing a roadmap to enhance and improve their current lifestyles. I'm going to let my co-chair speak now. Thank you.
Hello, my name is Emily Cooper. I'm the Vice President of Programs at the Chicagoland Chamber of Commerce, as I said. As a nonprofit leader and a program creator with over 10 years of experience, I'm passionate about building programming and partnerships that center equity, expand inclusion in the workplace, and help participants gain the skills and access they need to have a successful career. So I work to create a culture that aligns with the Chamber's values while helping Chicago businesses thrive and increase diversity and inclusion in all aspects of its business. So I'm here learning alongside all of you today. It's definitely, this is important for the business community to be a part of this and to be on the front line of this. The Ending Disparities in CKD Leadership Summit is the culmination of a learning and action effort with healthcare and public health stakeholders across Illinois. NKFI engaged these key stakeholders to help drive large-scale change through cross-sector collaboration and innovation. The ultimate goal is to ensure every person living with chronic kidney disease has the information and support they need to live long, productive lives. Today, you'll see the results of the work done by so many who are here with us today, and we thank everyone who contributed to these recommendations and the roadmap. And today, you'll see the agenda up. We've decided to strategically focus our efforts to meaningfully improve the lives of Illinoisans by developing a roadmap for early-stage CKD in primary care, using a collective impact model approach. On behalf of NKFI and NKF, we thank everyone who contributed so much to these recommendations and roadmap. Over to you.
Thank you. Thank you. Thank you, Emily. So before I get started, do we have any VIPs you'd like me to introduce right now? Okay. We'll keep it going. They'll come up with somebody. Monica says she got it. All right. Because VIPs are important. All right. So the agenda's on. The agenda's up there. We are at the goals for this meeting. So everyone who participated in our work groups. Is the work group here? How many people are here from our work groups? Okay. Could you stand up, work groups? Because we met online. Thank you so much. Let's give a round of applause for the work groups. Thank you. Because these are the people who made recommendations and suggestions on how we can improve the lifestyles of folks living with chronic kidney disease. And I want to thank each of you for committing to 2 hours today and make it clear that the beginning of this work is our commitment to moving CKD to the forefront of chronic disease recognition and treatment, rather than allowing Illinoisans to go undiagnosed until dialysis or death. Level setting, 2 hours only. So expect to listen carefully today. Make sure that those of you who are on the Zoom, again, we certainly hoping that everything is going okay in the Zoom. I guess Jackie and Monica, we would have found out by now if they couldn't hear us. But I'd like to take this moment to thank the National Kidney Foundation for being the backbone of this summit today, and for recognizing that Illinois is in the middle of the country, and we can show everyone how to create change in sustainable systems. And before we begin, again, a few reminders. For those of us who are joining virtually, please introduce yourself in the chat, and I shall assume that it's taken place. We will have a couple of question and answer portions during this summit, and for those of you who are virtual, you can put the questions in the Zoom Q&A function at the bottom of your Zoom screen, and we'll be sure to answer them. Somebody's going to get, I believe, thank you, Miss Amanda, too. Amanda's been working on this for 4 months, too. Give her a round of applause. Thank you. Because Amanda, I have to stop and take time to say that Amanda lost a very dear friend of hers within the past week, but she kept rolling and she kept going. And so, Amanda, I know it was hard for you, and I tell people, each day counts. You never know. This is the day. So thank you, Amanda, for working through your grief and helping us today. So we're about to move to slide 5, the CKD patient story. How we doing? All righty. The Ending Disparities Initiative is engaging many leaders and change makers throughout Illinois to identify and implement successful strategies to improve the diagnosis and management of CKD in primary care settings. To begin today's program, we thought it would be helpful to hear a patient's perspective that will illustrate where we are falling short. Please welcome Ms. Monica Fox, CKD patient and Director of Outreach and Government Relations for the National Kidney Foundation of Illinois. Thank you, Monica.
Good morning, everyone. I am a very grateful kidney transplant recipient. What I didn't know at the beginning of my journey is that 37 million people in the United States have kidney disease and 90% don't know it. I was one of the 90%, and I'll never forget the date that I found out. November 13th, 2013, I went from work to the ER to the ICU. And the last thing that I personally recall is driving myself to the ER and sitting in a wheelchair at the registration desk. My sister rode with me. People say she must really love you. I said, then I recall my sister Betty saying, your heart rate is high and erratic, and your kidneys have failed. Your kidneys have failed echoed in my head, and all I could think of was, how did that happen? Then she said, you've got a real fight ahead of you. What are you gonna do? I said, I've got to fight because Olivia needs me. She said, they need to put you to sleep, stabilize your condition. And I said, okay, but I need to know who's responsible to wake me up. So the cardiologist appeared like from out of nowhere and answered my question directly. And I explained that I had a daughter in college and she needed me. And he said, I'm gonna wake you up and you'll go to her graduation. Spoiler alert, I did attend that graduation. Yep, you can clap for that. I learned later that after putting me into an induced coma, they used the paddles to shock my heart back into rhythm, put me on a ventilator, got me stable, inserted a chest catheter, and gave me the first of my 3 years' worth of dialysis treatments. And there I was, unconscious and fighting for my life. They said that I wouldn't survive the first 24 hours, but I did. Yes, and when I realized that that had been my fate, I said to myself, God saved me, and there's something for me to do, and it's gonna be my mission to figure that out. What I know now that I didn't know then is how much I had to learn about kidney failure, its treatments, and how to not just survive, but to thrive. It soon became obvious that my mission was to educate others after educating myself, and to position myself to help others find a better way to and through kidney disease. So here I am in a career that allows me to work with esteemed groups like you, and in this case, to help figure out ways to move kidney care up the continuum and reduce the number of people progressing to kidney failure. I'm a lucky girl, but I must admit, I did not feel lucky in November of 2013. It was an abrupt, drastic life change for me and my family, emotionally, financially, socially. It wasn't easy. Nobody should have to endure that abrupt life change, but the truth is, so many people do. This summit gives us the opportunity to consider ideas that can make a difference. Although I did not have high blood pressure and diabetes, I've been told several times that there was a bit of protein spilled in my urine. They would explain it away and I would be relieved. Due to moving and changing health insurance, I changed PCPs many times. I now know that I should have carried forward that information and asked for further testing because that was a sign of kidney disease. If I had asked, I may have learned about my kidney disease at an earlier stage and possibly could have avoided dialysis. I could have slowed or stopped the progression of it. If I had known, I would have asked. We need more education, awareness efforts, and earlier testing requirements. Although I share my story often, it's not easy. It's a constant reminder of the almost impossible journey I've lived, and it's a reminder of the missed milestones and disappointments that my daughter and my family had to endure, the life changes that I and other family members made due to my illness, but it's also a reminder of the blessings that I've experienced due to the gift of organ donation and transplantation. I'm here to enjoy my dear 2-year-old grandson. I'm able to travel again without scheduling dialysis treatments. Overall, my story has been one of tragedy to triumph. My hope is that we can find a way to take the tragedy out of other people's stories and move straight to triumph. Thank you.
Thank you so much, Ms. Monica. What a powerful story, and a reminder why we are here today. To get us started today, we have a Slido poll with just 3 questions about your very own knowledge of your own health and vital signs. For this Slido poll, you can use your own mobile devices to scan the Slido QR code that will appear on your screen. Is it going to appear? Yeah, it's coming. All right. Or visit the Slido website link in the chat box to participate. All right. So the questions were up there. I was going to read them, but good job in the back, Creative and Digital Services. So go on, you guys, go to the QR code and take a peek at those questions and see what you know about yourself. How about that? Thank you. I'll give you a moment. Amanda, how we doing with the chat box? Good? Okay, good. Everybody's okay with the Slido? You've gotten the poll? Give me a hands up. Yeah, not? Okay, good, good, good. All righty. Whoa, look at there. Okay, so the first question, do you know what your cholesterol level is? Whoa, good stuff. All right, that's pretty good. All right, the second question, do you know what your blood pressure is? Wow. Well, now, you know, we're at University of Illinois UI Health. We can take care of that right away. I'll call somebody over right quick. We can take care of that. And question number 3, do you know what your eGFR is? Test of whether you have kidney disease and the stage of it. So let's see how many people know that. Oh, you guys are, ooh, good for you. Good audience. All right, good. All right. Well, thank you for your participation. And gosh, Jackie, I remember, I'll go back 30 years. We didn't have cell phones 30 years ago. So the use of technology and the way that we are presenting this format today, 21st century technologies have changed a lot. And I'm sure, Monica, that the infusion of technology with your services probably was quite different from it was even 20 years ago. But Monica, we are glad you're still here. And you know I love hearing your story every time I hear it. So, hey. All right, good. We shall carry on. Thank you so much. Thank you, everybody who participated in the poll. All right, we should be at slide number 7 now. CKD public health burden. Thank you so much. All right, so again, thank you for your participation in that poll, because you didn't have to, but you did. But you guys are all A honor students, I could tell that. So the results of this poll remind us that while many of us know our BP and cholesterol, and congrats for that, yet very few of us know how our kidneys are doing. You're not alone in this. If you are at risk for kidney disease, this is a number you should know. Chronic kidney disease is a huge, and I say huge, public health burden. The prevalence in the United States is estimated about 37 million adults, but 90%, I'll repeat that, 90% remain undiagnosed. Now stop and consider that. Only around 10% of people with kidney disease know they have it. While kidney failure and dialysis are most people's fight through this when it comes to consequences of CKD, in reality, cardiovascular mortality is a more likely outcome than kidney failure. I'll repeat that again. In reality, cardiovascular mortality is a more likely outcome than kidney failure, and the cardiovascular impacts of CKD represent an underappreciated health burden. Are we on slide 8? CKD often goes undiagnosed. Yes, the graph. This graph shows the actual prevalence of CKD, the orange bars, compared to a diagnosis of CKD or those who know they have it, the purple bars. You will see that even in stages 4 and 5, the most severe stages of CKD, less than half the people have a diagnosis. Why does this matter? Because in early stages, especially by stage 3 CKD, there are both health impacts, including, as I mentioned, cardiovascular mortality, healthcare costs, increased utilization, increased hospitalization, all from CKD. There is a huge opportunity through increased diagnosis for better management of kidney disease, which can result in reducing the mortality rate as well as reducing healthcare spending. So the drop, if we look at the prevalence between stage 3 and 4, the steer drop is not due to people not progressing or managing CKD well, but due to people dying of cardiovascular disease before they can progress. Again, this helps to illustrate the cardiovascular impacts of CKD. Are we on slide 9? Thank you. According to the 2017 U.S. Renal Data System report, nationally, people with kidney disease, excluding those with end-stage kidney failure, represent 13.1% of the Medicare population, but 23.8% of the Medicare cost. Patients with kidney failure represent 1% of the U.S. Medicare fee-for-service population, FFS, but account for approximately 7.2% of Medicare FFS spending. ESRD spending equals $49.2 billion per year. I'll say it again. ESRD spending equals $49.2 billion per year. Again, most people associate CKD costs with late-stage and end-stage CKD. But you can see from this graph, even in earlier stages, healthcare costs begin to increase rapidly. So I'm going to move to the chat with Amanda checking in. Is there anything, Amanda? We're good? Okay, all right. We talk about a report. There's a report. It probably should appear on the screen. There. All right, good. All right, we should be at slide 10. There are 2 simple and inexpensive tests. Serum creatinine with eGFR and urine albumin creatinine ratio required to diagnose CKD and understand its severity. Many of you are likely familiar with eGFR, and chances are that you have eGFR results for your patients or yourself in the medical record. But eGFR alone is insufficient to assess the severity of CKD and the likelihood of progression. The heat map shows how to use the 2 tests, eGFR and UACR, to stage a patient and assess their risk of progression. Looking at stage 3A, you can really see the importance of having both numbers. Someone with eGFR of 55 without a UACR, you might not brush this person off as a mild CKD patient or even dehydration or just age-related decline. And with normal UACR, you can see their risk of progression is only moderate. But if the person had moderate or severe levels, you can see the risk of progression increasing significantly. This is why both tests are really needed. If you're only looking at the eGFR, you're missing one of the pictures. The UACR helps us understand the severity and inform decisions, and it helps them make decisions. However, we know that most people at high risk for CKD don't get both of these tests, which contributes to the low rate of diagnosis. We should be ready for slide 11. We know that CKD, like many chronic diseases, is associated with significant racial and ethnic disparities. We wonder, where do these steer farms? At the baseline, there are no differences in CKD prevalence across country subgroups. And while there are some genetic links, genetic causes represent a limited factor in CKD incidence. Even the chronic condition, risk factors, diabetes, hypertension, have less to do with genetic causes and more to do with social detriments of health than any genetic ancestry. As we progress into late stages of kidney disease, we begin to see how the disparities appear. Communities of color, Black, African American, Hispanic, Latino, Native American, and Native Hawaiian, Pacific Islander communities are all disproportionately impacted by CKD relative to their percent of the population. And we see disparities in care, would you believe that? Such as less access to timely referral to nephrology. Moving into stage 5, kidney failure, we see significant disparities start to appear. Communities of color are less likely to be on home dialysis modalities, receive fistula, be identified as a candidate for transplant, be referred for evaluation, complete the transplant evaluation, be placed on a waiting list, secure a living donor, and receive a kidney transplant. And Monica, when I think about all that you just said, how blessed she was, because the records say, the research says that we're less likely to see this. We know that we need all of these things to implement the strategies to close these gaps in care that we see in late-stage CKD. But we also need to focus on better understanding the factors that conspire to influence progression of kidney failure. What is happening in early stages leads to disparities in outcome and care later in disease progression. For that reason, NKF focuses our health equity efforts on both addressing late-stage disparities and on improving early diagnosis, and explore the outside factors that are influencing CKD progression. And for us, that starts with ensuring as many people as they can to learn as early as they can about CKD. Now I'm going to turn it back over to my co-chair, Emily, to review the state of CKD in our very own town, Illinois. Thank you.
So when we examine Illinois-specific data, roughly 1 in 7 adults in Illinois has kidney disease, but 9 of 10 are unaware. This translates to nearly 1.5 million adults in Illinois likely having kidney disease, but fewer than 200,000 adults are aware of their condition. Half of all cases of kidney failure are caused by diabetes and hypertension, as approximately 40% of people with diabetes will develop kidney disease and approximately 20% of people with hypertension will develop kidney disease. You can see from this slide, the number of people in Illinois at risk for CKD just amongst these two conditions is quite high. Slide. Here you can see the 2020 CDC Behavioral Risk Factor Surveillance System data showing rates of diabetes and hypertension over time. These numbers are rising, likely contributing to more people developing chronic kidney disease. However, despite these increases and the advancements in game-changing CKD therapies, the stable low CKD rates show a lack of action in CKD diagnosis. We must act now to change these trends and reduce the morbidity and mortality rates across the state. Let's take another look at the CKD population across the state. This 2019 Center for Medicare and Medicaid Services map displays the prevalence of diagnosed CKD among Medicare beneficiaries under the age of 65 years across Illinois. We can see the burden is not evenly distributed across the state, but there are large portions of the state with high rates of CKD. Moreover, as of 2020, 34,458 Illinois residents were living with end-stage renal disease. There were 5,466 new cases of kidney failure in 2018, with 5,312 patients going on dialysis, and only 154 of those were able to receive a transplant. Also in 2020, only about 1 in 4 Illinois patients on the waiting list received a kidney transplant. This slide depicts the burden of CKD and state of care in Illinois. From analysis conducted by AstraZeneca's Atlas database this year, out of 155,673 patients with a CKD diagnosis in Illinois, 27.14% of the same population was low income. 27.11% consisted of the Medicare and Medicaid population, and 13.36% identified as Black. Conclusively, there is a disproportionate impact on low income and communities of color. This slide also shows the utilization of key medications to manage CKD, both new and longstanding therapeutics. And you can see from these percentages, we have lower than desired utilization of these therapies to manage CKD, another opportunity for improvement. There are a tremendous number of individuals at risk, but the vast majority do not receive appropriate testing to get a CKD diagnosis. Recently published data in Diabetes Care reported that of 28,295,982 at-risk patients, 80.3 did not receive guideline concordant assessment during the study period. Although nationally, the testing rate was around 20%, even less, 18.6% of at-risk patients in Illinois received the appropriate testing, and the trend was increasing over the years. Most patients in this study did have an eGFR, but the majority were missing a UACR test. We also have some state-level data amongst Medicare beneficiaries in Illinois. This data was provided by Centers for Medicare and Medicaid Services to Delagen. There were 719,515 people at risk for CKD, individuals who had diagnosed diabetes, hypertension, or both. But only 124,503 people received both UACR and eGFR tests in the last 12 months. In other words, only 17.3% of at-risk patients had been properly tested. The highest rates of testing were among the patients with both diabetes and hypertension. But still in this group, approximately 60% did not receive both tests. You can see from that graph that similar to the data from the previous slide, missing UACR drives a lot of the testing gaps, and UACR testing is lowest in patients that just have hypertension. These four graphs display the demographics of this at-risk population. While across all groups there are testing gaps, African Americans, people living in rural areas, and younger people under the age of 65, and those considered very elderly, 85 and older, experience the lowest rates of receiving both UACR and eGFR tests. This conclusion aligns with other national data and what we see in the literature. So, why does this matter? This slide shows that many of the standards of care or best practices for CKD are not being met, and outcomes have not been improving over time. People with CKD have a high prevalence of uncontrolled hypertension and diabetes. Breakdowns in CKD care are not isolated to testing and diagnosis. Significant gaps in guidance concordance exist across the spectrum of CKD progression. Recalling the Illinois data we showed just a few slides ago, utilization of key medications for managing CKD is low, around 55% in Illinois, which is slightly higher than the national data shown on the slide. And only a small percentage of patients with CKD diagnosis in Illinois are prescribed CGLT2 inhibitors, 8.80%, which is an innovative treatment for CKD that can slow progression. Increasing utilization of recommended medications and other therapies to manage CKD starts with appropriate testing and diagnosis. However, there is hope for changing the CKD trajectory through population health-based approaches. This slide demonstrates the success that the Indian Health Service has had in reducing diabetes related and end-stage CKD by going upstream. The IHS implemented a series of population health changes focused on improving outcomes for diabetic kidney disease in their population. This chart shows the incidence of kidney failure in people with diabetes, with the green line depicting the American Indian and Native American population. Native Americans had the highest incidence of CKD, but through focused efforts to implement population health strategies, the rates of kidney failure from diabetes among their populations declined by 54%. They went all in on early recognition, management, and recognizing social determinants of health that contribute to CKD and acceleration over time. Although it's a health system that is underfunded with fewer resources than the average health network, they prove that focused population health strategies in early stages can have an impact. All these strategies are easily replicated in other health settings, including yours. The success of this model is what is possible to get a system to change for increased testing, early diagnosis, and more effective management. If they can do it, we can do it in Illinois. And with that, we're going to open, I believe, to some Q&A from the chat and in the audience. Any questions? Yes. And could you, I'm so sorry, could you come to the microphone just so everyone can hear you virtually and in the room? Thank you so much.
Just a quick point of clarification. This is on. Oh, testing. Can I speak up?
Yes, we can all hear you.
So I just want to point of clarification to make sure, because there's a lot of terminology in terms of end-stage renal disease versus chronic kidney disease. Are we using that interchangeably, or can we be clear on what those different terms mean?
Absolutely. I go to the experts in the room for that. Thank you. We have your answer coming. We do a lot at the chamber, but we haven't covered this yet, so I want to make sure we got you the best answer.
Great. Yes, that's, great question. Terminology is so important. So chronic kidney disease encompasses, it's a broad term, and it's, typically it's staged. So there's stages 1 through 5, with 1 being mildest, and 5 being kidney failure requiring dialysis or transplant. And so that's the term that we use for end-stage kidney disease. But, we're very excited. Just want to talk about support of this initiative. Very excited, and great presentations today. And we're very proud to have UI Health as part of this today. We're also part of an initiative. This really dovetails with some of our research efforts within the city, and particularly here at UI Health, looking at the issue of chronic kidney disease and trying to better understand risk factors for progression and slowing progression. And a new initiative that we're involved with, collaborating with NKF and Monica Fox in particular, is the Kidney Precision Medicine Project, which is funded by NIH. And it's really trying to look at better understand factors responsible for causing kidney disease, its progression. And as part of this initiative, which is, across the country, patients with kidney disease actually undergo a kidney biopsy, a research kidney biopsy at study entry, so that we can really better categorize cases, because the things that we have now in terms of understanding causes is very rudimentary, and probably in 20 years we'll have much more precise understanding of causes of kidney disease. But thank you. So there's a question in the chat. If ACE inhibitors, angiotensin receptor blockers, ARBs, are such low-cost medications, why are they underutilized? And that's a great question. Complex. They shouldn't be underutilized. They're, at this point, there's generic forms of these drugs, and they're very low cost. So I think some of the issues that were, really addressed earlier in terms of recognition of disease and education Education both of patients and providers is key.
Should I use the microphone? Yes. And I think that's Thank you. I think the question is, and I'm very grateful that there are always money for NIH. My question is there any initiative that actually are refreshing this information to doctors that serve minority communities? Because, you know, the majority of our communities go not to the specialty hospital, but the time that they get to these hospitals, they are just way long into this condition. So I remember when we were working on diabetes, we start by community hospitals. We start by clinics just to tell them about what is the best practices on diagnosis, screening, and treatment.
Great question in terms of public health approaches. Okay, great. I was going to pass it to you.
All right, I appreciate that. So good morning, everyone. Thank you for being here. My name is Elizabeth Montgomery, and I'm the National Vice President of Learning Strategies and Population Health Programs at the NKF. So to your very important question, right? There's a lot of energy and effort occurring in large integrated health systems around kidney disease and trying to streamline costs and improve outcomes for people who have ended up in stage 4 and are ready to crash into stage 5. But what about the rest of the population that's cared for in federally qualified health centers, community clinics, or who may have trust issues and may not be receiving care at all? So the National Kidney Foundation has partnered with local departments of health in a number of states where we have developed a CKD data strategy, where we work specifically with federally qualified health centers, essential hospitals, community clinics. We go to those organizations, we bring tools and resources into those institutions to help them better understand the scale and scope of chronic kidney disease in their populations. We help them triage and build out a chronic kidney disease strategy, help update the electronic health record with tools, resources, and clinical decision support. And then we have a CKD learning collaborative model where we actively work with those institutions on the care coordination and that aircraft carrier turn to take what is generally unrecognized and move it into an important part of the population health model. So if there's an interest in having a direct conversation about that, I can provide more information on the work that we're doing in other states where we are specifically targeting communities, including the Spanish-speaking community, to bring all of the tools, resources, and support to those institutions in culturally appropriate preferred language approaches. Love the question.
Thank you, Elizabeth. You might want to wait a second. There's another question from the chat. We'll see which of you answered this one. With the disparities in low income and underrepresented zip codes, how do you accelerate the need to have preventive testing for these groups? Also, cost tends to be prohibitive, and that's my concern. For example, there's a 16-year difference in life expectancy for my zip code as compared to low-income zip codes just around health disparities.
So I'll definitely address that question. Thank you, Monica. Thank you, Pam. That's another really important consideration. So the first thing I will say is that the 2 tests that diagnose chronic kidney disease are widely available, relatively inexpensive, and generally covered by Medicaid. So anyone who has the ability, who is struggling financially and has Medicaid access, generally have access to these 2 tests. So that's the first part of the response. The second part is that there are people who have no insurance. There are undocumented people in our community who are afraid to pursue health care and don't have that support. So how do you get those tests paid for? Right now, the National Kidney Foundation is making these tests available for free to anyone who goes to our national website for the 33% campaign. If you go to minuteforyourkidneys.org, you will find a risk quiz there that can be completed as an individual, and you can order a test to be sent directly to your home so that you will have free information about the health of your kidneys that's provided as a result of this website and this available testing. If you are someone who works in the community, have a community clinic, an FQHC, and you're looking to address this question for individuals in your populations, would love to have a conversation with you about how we can work to orchestrate that free testing for your communities. So please feel free to hunt me down. I'll drop my email information into the chat so we can have a conversation about how we might work with you in the same manner that we've worked with other organizations to get this free testing into the community. Anything else before I leave?
Maybe you could join the people present, the NKF lead, like that peer mentoring program.
Sure, of course. So, okay, I'm going to put on the NKF promotional hat and let everyone know that we have a variety of national programs, as well as the programs supported by the National Kidney Foundation of Illinois to support people who are trying to understand how to navigate this really difficult journey. Getting a diagnosis is only the first step to moving through this complex management that's associated with a progressive disease that impacts you in ways you wouldn't expect. So there are programs that are offered locally as well as at national level where you can call and speak to a social worker, get some information, get help navigating the website. There's also a program called NKF Peers, which is a peer mentoring program where there is an opportunity to really speak to someone else who's been on the journey with you or on a similar journey so that they can provide from an experience perspective, not a knowledge perspective, an experience perspective, what they did to get the outcomes that they realized in their own journey. So again, I'll drop my email information into the chat. I'm sure my team are probably dropping some links into the chat as well, where you can find this information or connect with us if there's more information you'd like to have.
Thank you, Elizabeth. Definitely having a peer with lived experience is very valuable. I also wanted to mention that in Illinois, for people who are who need free testing, we do have our Kidney Mobile, where we go throughout the state from March through November, all throughout the state, testing for free, comprehensive kidney screening. So at the table in the back, if you're here in the room, you can get more information about that from my colleagues back there.
Thank you. Are there any more questions from the chat?
I actually have one if I could.
Girl, listen, I got my glasses on and didn't see you. I'm so sorry. We got a script, you all. We're working off a script. Okay, and don't go too far, Elizabeth, because I'm certain I can't answer this question, but hello, who are you?
Good morning.
What's your name?
My name is Leah Howell, and I'm actually a recipient. So on behalf of all recipients, thank you all for the work
Bless
that you do.
Bless you, and thank you for coming today.
Thank you.
Thank you so much.
Absolutely. So I have been involved. Joey is my kidney. He turned 19 this past Sunday,
All right,
and so
Joey.
have been
Hey,
familiar
Joey.
with the work.
Joey's a teenager
yes.
still. All right
Yes.
now. Okay.
But I am curious, over the last couple of years, we've seen a change in the way that EGFR is calculated, removing race from that calculation. So I'm curious what that has done or what we anticipate that to do, both to increase access as well as create potential barriers for people, as recipient or potential donors.
All right, then. Mina, could you give that mic to, you can take it there. Thank you. We got you, Joey.
Yeah, thank you for that. Another really great question. So I lead the team who led the implementation of the new race-free equation. So I can tell you that the outcome, first of all, the uptake of that new equation is not what we all would want it to be. So let me start there, that there's data that suggests that only 30% of certified laboratories in the United States have actually started to use the 2021 CKD equation. So if you are at a hospital system, an FQHC, you have any access to systems in rural areas, we really would like to talk with you about what we need to do to get those pathologists to swap out these equations so that we can ensure that a social construct is not utilized in the assessment of health. What we are seeing is that the bag is mixed. There's lots of papers out there now that clearly illustrate that the impact of this equation is felt most importantly at early referral to transplant. That the new data illustrates that individuals who referral were delayed have expanded access to getting on the deceased donor wait list earlier. There's lots of consideration for upstream, but overall, I would say that this equation is more equitable in terms of its application across all population groups, and the data that's been published recently supports that.
Thank you, Elizabeth. To those of you who are watching us via Zoom, I do understand we've had a few glitches. I'd like to take time to apologize. I asked the team in the back, how's the weather outside? Because sometimes the weather makes a difference. So I hope, how's Zoom doing back there, you guys? Nathan, how we doing? Okay, so those of you who are online, I hope you can hear me. Can you hear me now? Keep working with us. They're working on it. So thank you so much. So we'll move on. Now is the time to bring Elizabeth back. That's why I told her don't go too far, to discuss the roadmap process that has led us to where we are today. I'm now going to turn it back over to Liz of the National Kidney Foundation, the backbone organization for this collective impact initiative. Thank you, Liz.
I didn't really intend to do this much talking today. So this is what I was supposed to say. So I want to thank you, Dr. Hayes, for hosting this conversation today. And let's talk a little bit about this broader Ending Disparities in CKD initiative. It's a part of a much larger strategy called the Advancing Health Equity Initiative at the National Kidney Foundation. The goal here is to ensure that we can address the gaps that were mentioned earlier with regard to primary care awareness and understanding of kidney disease, and ideally get people, especially those who are in populations that are disproportionately affected by CKD, diagnosed and on some treatment plan earlier. Illinois is the third state to have embarked on this journey. As you can see, not yet from the map, that will eventually be behind me. Maybe? There we go. All right. So we've done this in a number of states already, and we are in the process of rolling this out in an additional 6 states over the course of the rest of this year. Our goal is to really change the nature of the discussion. Right now, when you hear kidney disease, you often immediately associate it with end-stage and kidney failure, and we're using these summits as an opportunity to really change the conversation and make sure people are aware that any underlying chronic kidney disease significantly contributes to elevated cardiovascular risk, events, and mortality. And so by getting upstream sooner, we have an opportunity to better manage that risk in primary care populations. Through our compelling data story, we hope that we will be able to increase the sense of urgency for action. We're hoping that our partners who have engaged in this process with us are willing to take a little closer look at their institution and their data to see where they are in terms of the landscape and ideally partner with us to drive change. So, recognizing the challenge, the significant lift that's involved here, to get healthcare to engage around a disease state that generally is sort of treated as an orphan child. We can't do this alone. So what we've done, and what this summit is the culmination of, is to build the framework for a collective impact model, which is the next slide. Yay. So a collective impact model is an evidence-based strategy that has been deployed in other areas of public health. It's been employed in environmental health, and it's employed in a number of education and just community settings that allows for bringing people together to build a locally grown roadmap that, this is not the National Kidney Foundation's issue and challenge. It is impacting everyone in this room and the institutions they represent. And so the vision here is not for our organization to bring our agenda, but for people who are concerned and engaged to tell us what they think needs to be done. And that's the framework for collective impact. So we've been moving this forward as the background organization. This is the beginning of what we hope will be several years of collaboration and partnership working together to operationalize the recommendations that have been suggested by the work groups and to really begin to change that aircraft carrier and positively impact the 1 million people who are in the state right now who remain undiagnosed. So I think, Dr. Hayes, I'm supposed to turn that back to you.
Thank you. I'm going to sit right here because I'm going to let Ms. Jackie prepare to go to the stage. So thank you so much, Elizabeth. Thank you. Let's give her a hand. So now with Ms. Jackie, we're going to get into the findings of our Learning and Action Workgroup discussions. I will turn it over to Jackie Burgess-Bishop, the CEO of the National Kidney Foundation of Illinois. Thank you, Jackie.
Thank you, Dr. Hayes, and thanks to everyone that's come out today, everyone that is looking virtually. We're working on the technical opportunities and challenges and want you to stay with us. This is a very important and dynamic conversation. We are honored to be the third state to launch this health equity initiative. I want to discuss the process that we've embarked upon for the initiative with a goal to decrease disparities in diagnosis and appropriate management of kidney disease. The star, okay, we're looking at slide 28. The star shows where we are today, thanks to your support. We began compiling data on risk factors, testing, diagnosis, and quality of care to create the data story on the public health burden of CKD that was shared earlier today. We also spent significant time mapping out the key stakeholders that include leaders and change makers from various organizations across the healthcare, public health, business, and community organizations to participate and support this initiative. Looking at slide number 29. We identify key thought leaders representing a diverse spectrum of healthcare and public health fields to participate in our Learning and Action Workgroups, where we develop the strategies to improve CKD testing and diagnosis in primary care in Illinois. And you'll hear more about that in a few minutes. Such leaders included quality improvement and population health leaders within the healthcare systems, medical directors and population health leaders within healthcare payers, professional membership associations in the fields of medicine, laboratory medicine, rural health, community health groups, community health workers, and hospital associations, government agencies, and policymakers, and also including our community-based organizations and CKD patient advocates. We thank you, we appreciate you. As we move to slide 30 and talking about our work group participants, as mentioned before, there were 4 groups engaging around a specific topic. The topics include clinical considerations, engaging community and community-based solutions, wellness and prevention, or CKD population health model, and policy, payment, and quality management. Each work group met 4 times for 1 hour each session for a total of 16 hours of facilitated discussions. In total, we engaged 38 individuals representing 29 public health, community, and healthcare organizations in Illinois. And as said before, we are so appreciative of the leadership of our work group facilitators noted on the slide who helped navigate these fruitful discussions. So can we clap for our health facilitators? You're going to hear a little bit from them. All right. As stated, we could not have gotten to this point without our contributors to this work, and we really appreciate their brain power, enthusiasm for the work. I can tell you some of the conversations became very robust. They ended in sometimes a debate, but at the end of the day, we focused on the strategic goal of moving CKD up the continuum. All right, looking at slide 31, some of the key theme quotes we had with the 4 unique work groups. Each work group followed a similar agenda for the sessions. The first discussion in each group was around the barriers or appropriate CKD testing and overall CKD care and management. We wanted to highlight some of the quotes you see on the screen that came up in these discussions and organized them on the slide from the lens of different stakeholders, your peers, our peers here in Illinois. The first and most frequently shared barrier is awareness. Across the board, regardless of the stakeholder group, everyone mentioned the challenge of awareness. Again, only 10% of people living with kidney disease are aware that they have it. If we look at slide 32 and we focus on the barriers, we heard about gaps in knowledge that we need to address in the clinical community, such as CKD is common. CKD increases cardiovascular risk, and CKD is not a death sentence, but can be a manageable solution. Payers and health systems are also impacted by low levels of awareness, specifically around the value of upstream intervention in CKD. Most are focused on improving patient outcomes and reducing the cost of care associated with late-stage kidney disease. But the reality is, late-stage outcomes can't improve unless people are identified and managed earlier. We know that with new medications and to slow the progression and reduce cardiovascular impact, early recognition is more available now and more important now than ever. Speaking of cardiovascular impacts, there's another area where awareness could be improved. Most people aren't aware or lose sight that CKD isn't just about kidney failure, that kidney disease is a disease multiplier, which elevates cardiovascular risk significantly. The cause of CKD is another awareness gap to be improved. While diabetes and hypertension are 2 leading causes of chronic kidney disease, we can't overlook the underlying factors driving the disease, the social determinants of health, and this was previously mentioned. We look at the impact of poverty, food insecurity, other social disadvantages that are associated with higher rates of diabetes, hypertension, and kidney disease. We know that there is an unequal distribution of resources across populations, with communities of color and rural populations that have less access, which drives health disparities. More data is needed to fully understand the impact and risk, and the impact on risk for chronic diseases. We are well aware of that. And clinicians and payers need resources to address these underlying factors so individuals can manage their health. When we look at the system challenges that exist, we heard from clinicians and health systems about the challenge of competing priorities. Just want to know, how many clinicians do we have in the room? If they can raise their hand, and those that are virtual, you can virtually raise your hand online. So the mantra of competing priorities is very real and a daily challenge. Time constraints and staff capacity also lead to some of the challenges. The work group participants also suggested that linkages between healthcare and the community are not optimized as much, that can result in fragmentation. There are tools in the toolbox, that's good news, such as pharmacists, community health workers, and community programs that are available but tend to be underutilized. Electronic health records are far from perfect. There are few clinical decision support tools for chronic kidney disease, and some make it hard to even find the laboratory results indicating a person may have CKD. Interoperability is another roadblock to improve CKD care. So a lot of these issues, a lot of these points were brought up within our work groups. For many clinicians to find in the EMR is CKD can be buried. Given the time constraints on providers, efficiency is paramount, and multiple clicks to find an outside lab result may mean it may not be viewed or may not be viewed in a timely manner. We also face a lack of measurement for CKD. Not having the full picture of the impact of CKD in the state is a significant barrier to our success. We need clear guidelines and metrics to be accessible to key stakeholders to benchmark performance and understand areas for CKD improvement. We have relatively briefly overviewed the thoughts, and another thought that had come up deals with the issue of health literacy in the communities that we are working to change and challenge and to continue to educate and to navigate. So the issue of health literacy is one that, particularly with CKD, that we're looking to impact as well. We need to ensure that educational tools provide clear, easy to understand information and lots of visuals. As individuals are skilled in providing that education in a culturally relevant and respectful manner. We also need to identify trusted CKD messengers who can help improve the accessibility and consequently reach the populations that need to be reached. So what we're looking at now, let's see, the chat and QA monitor. Amanda, have we copied into the chat box? For more information, you can visit nkfi.org/CKD-intercept. So when we talk about, we're at slide 33, that we need all of you. As a team, we then distill down the ideas and align the recommendations from the 4 groups to compose the statewide strategy that you're about to see. As we move into the discussions of the solutions identified by our work groups, I think it is important to keep in mind that while this may seem like a daunting challenge, history has shown that even a small group of committed people working together to address barriers and identify solutions can drive change. So now we would like to introduce the recommendations. All right, so we should be on slide 34. So Darren, you can start to say, come on down. All right, okay, all right. Increasing public awareness and understanding of CKD, recommendation 1. A common theme, as already stated, is that the awareness is low. There are existing tools from NKF and others that may be able to be tailored for the local communities. And Liz talked about a number of them, but we also, and it's not a but, it's an and, we aim to expand engagement with various community partners, including faith-based community leaders, community health workers, public health professionals. A lot in Illinois is going on in that area. There's a number of collaboratives a number of us are aware of that have been formed within the state that do combine the different constituencies and what we're looking at for CKD, because as we know, it has tended to be a downstream disease, which is the purpose of this summit, and other key initiatives to move it and raise that awareness and bring it upstream, is to assure that within these collaborations, the impact of kidney disease is understood, is known, is part of the solution and part of the resources to continue to move us forward. So what we look at is we must ensure that stakeholders are representative of the communities that are facing the highest burdens of CKD. And to share more about the recommendation to increase public awareness and understanding of CKD. Darren has joined us, who was one of our facilitators. And what I'd like for you to do, I'm going to just step aside, Darren, is to share the discussion, a little bit about the discussion that took place within the work group and the origin of the recommendation and how you feel this recommendation will make a difference. So thank you.
First off, I just want to thank NKF and NKFI for allowing me to participate in this summit, but also the work groups leading up to it. After hearing Monica's story earlier, it tells us how critical this work is, so I feel exceptionally honored to be able to participate. So with our work group, really a lot of conversations centered around the different organizations within communities in which people access healthcare. And so we found how critical that is to look at each of those different organizations and how they can contribute to the bigger picture. And so I think that moving forward, that those next steps are going to really involve bringing those groups together, because we know that not all populations seek healthcare in the same manner. So whether it's through a faith-based organization, a community-based organization, a healthcare system, FQHC, you name it, there's a multitude of options that people have to seek out that healthcare. So that's centered around a lot of our discussions. And then secondly, the other part was the literature that exists. You know, whether or not the literature that is out there is actually consistent, and what medium is being used to deliver that information. As we know, as populations have continued to grow, there's a new method out there, social media, and are we utilizing that to the best of our ability? Because paper pamphlets may not be what everybody needs. That may still be valuable to some populations, but we have a lot of tools within our toolbox that we can continue to use and increase the accessibility of that literature. So those were probably the two main themes I would say focused around our work group.
This work group was extremely active, and so the second facilitator is going to join us in a minute to discuss another component of the recommendation. Another recommendation was to leverage our collective impact model to implement a CKD awareness campaign for the state of Illinois. We know Liz already brought up the 33% in terms of awareness, your status, the follow-up testing. Here in Illinois, we have the campaign that we have launched, Kidney Health for Life, which looks at from the beginning or from the prevention all along the continuum. However, more work to do, more work to be done. And so when we looked at the collective impact model that can include payers, employees, business community, pharmaceuticals, biotech companies, and community-based organizations, we're going to enhance through this recommendation, based on this recommendation, and leverage part of what Darren mentioned, but even going more, looking at digital advertising, radio, feedback from stakeholders engaged in this collective impact model. And more specifically, we hope to learn from the collaboration of our Kidney Disease Prevention and Education Task Force that is chaired by Senator Maddie Hunter, Illinois State Senator Maddie Hunter, and Representative Maurice West, and has a diverse group both from multiple perspectives, industry perspectives, that at the end of this year will be developing a kidney plan. So information from this summit, as well as I'm looking at Liz now, as information that's transferable from other states, will go into that plan, as well as going into our collective impact model that's going to move on beyond this summit. So given the impact of social determinants of health for the risk of kidney disease, it's especially important we build connections amongst partners who provide these services in developing messages and disseminating information about available services and resources. So with that, what I'd like to do now is call Lyndon Schuyler, we call her Sky, who is the second facilitator for the wellness work group. And comparable to what we asked Darren, what's the impact you feel that based on the work group can come from that recommendation of that focused awareness, use of media, as well as moving forward in this collective model? So Sky, thank you.
Thank you, Jackie. I also want to echo what Darren had to say. It has been a tremendous, tremendous honor to be associated with the National Kidney Foundation of Illinois and with their various programs for the past 3.5 years, I think, 3.5 to 4 years. One of the first things we talked about in the Wellness and Prevention Group really had to do with the lack of understanding of chronic conditions as a whole, and the fact that most individuals, even those who suffer from those various chronic conditions, don't necessarily understand that chronic conditions don't travel alone. That's sort of my way of putting it. If you have one, chances are you have another, and maybe another, and maybe even another. And chronic kidney disease, I have learned over the last few years, is one of those that frequently travels with diabetes and high blood pressure. So the impact really had to be, I think, getting firming up an understanding that these chronic conditions are not singular, and that there are other organizations and other, I'm going to say, individuals and groups that could form support around helping people understand those chronic conditions and how they work together. And one of the tremendous things that we saw coming out of the pandemic, if you can say there's something wonderful that came out of the pandemic, it was an understanding that we really can't function alone. We have to have partners. We have to have other people that can help us move from point A to point B. And those partnerships became more and more valuable as the pandemic progressed. And I think a lot of those partnerships just within the state of Illinois have continued. And the ones I know that are on the board also are other organizations that deal with chronic conditions. There are other healthcare organizations. There, you see, again, you keep hearing about the FQHCs, and you hear, again, about the chronic disease programs, bringing all of these people together with an understanding that this doesn't have to be just one person's fight or one organization's fight, that this really can be a much greater impact if we work together. Thank you.
Thank you, Sky. Absolutely. All right. All right, when we should be on slide 36, increasing public awareness and understanding of CKD recommendation 3. Dan, you get the come on down, all right, our message. So for this particular work group, which focused on community-based solutions, the work group there were 2 work group facilitators. Dan is going to comment today. Our next recommendation was generated by the Engaging Community and Community-Based Solutions work group. To partner, these organizations were a cadre of ambassadors that we said that need to disseminate CKD information and resources. That was one of the key recommendations, to have this cadre of ambassadors to communicate the message. Through this strategy, we aim to engage multiple stakeholders, including public health stakeholders outside of the CKD space, as you heard articulated so well by Scott, to make an active role in disseminating the campaign to the community. Deploying a train-the-trainer approach to support these organizations and CKD messengers and messengers were the necessary CKD tools as well as resources to address the social determinants of health across communities that disproportionately are impacted by CKD. These CKD ambassadors should be equipped with information about chronic kidney disease, other health conditions, and health-related social needs that may impact the risk of chronic kidney disease and or the ability to manage this condition. Another method for dissemination is a population health approach to integrate CKD educational materials and resources and programs for other chronic conditions, identifying opportunities to cross-pollinate our awareness and our awareness efforts with the incorporation of CKD awareness messaging to further reach and to reach in, removing silos and collectively working together to improve kidney health outcomes, whether it is across community activities, educational events, conferences, and other gatherings to disseminate resources. A multi-dimensional approach is necessary to overcome accessibility challenges and advance equitable solutions. We already talked about the opportunity to leverage social media that came. What happened that was really phenomenal with this approach that has been seen in other summits that we're seeing here is that you start to have those common threads that cross the different work groups, and the utilization of social media and other tools to educate, to inform, was also discussed in the community-based solutions work group. So Dan, the question I have for you in terms of, we talked about the recommendation solution, the impact of this community-based or community-focused approach. If you can mention for your work group, the impact you feel it will have on the recommendation. Thank you.
Hello, good morning. I'm Dan Leitz. I want to say thank you to Jackie. And I also see a few of my Donate Life Illinois partners in the crowd. Dr. Harry Wilkins. We have Team Illinois here. Kevin Smunt, good to see you again. I think as a whole, the community-based outreach as a collective group will be very impactful. I can say that we are partnering up with our Donate Life Illinois partners to make an impact on the community grassroots. At 79th and Cottage Grove, the Jack Lynch Center is partnering up with the National Kidney Foundation to do screenings there in the near future, which is going to be a huge impact on the south side of Chicago. Now, one of the things that I remember in our debate, heated debates at sometimes, which were actually pretty fun, was we wanted to make sure that we educate the patient as they go in and get their normal doctor visits to look for certain aspects of the testing. Many of the people on the panel said they don't even look at something like that. So we want to develop something along those lines to see if something comes up, this should be looked into, into furthermore, and they can bring that up to the doctor. And then on the other hand, the provider, rather than doing a 5-minute assessment, which most of the people claim that they were getting, to be able to see a few indicators and say this is something that needs to be looked at forward. So we would like to provide some education with that, whether it be in a pamphlet or taking classes with our fellow partners at Donate Life Illinois. And I think that would make a vast improvement in our access to this. So thank you so much.
All right. Well, thank you, Dan. I think for chat and QA monitoring, Amanda, are we getting questions? Not right now? Okay, then. Well, what we want to encourage at this point, we discussed this, but you can take the time to visit Minute for Your Kidneys, and to check out the 33% campaign for personalized results and resources from the NKF. If we move forward, thank you, Laura. All right, all right. She came forward for the clinician and healthcare system opportunities and for the clinical considerations work group. Each test and early testing and diagnosis for CKD needs to occur more in the primary care setting. We already talked about that. It was clear from the work group conversations that primary care clinicians need and want more tools and processes to help with diagnosing and managing CKD. Clinicians need the knowledge of the CKD testing and care management best practices, but they also need tools and processes to ensure they can adequately implement that knowledge. There is opportunity to leverage traditional venues such as grand rounds, conferences, or other institutional meetings to share CKD information. In addition, the group agreed more approaches such as the ECHO model should be used and expanded within the state. There are existing CKD ECHO models. One, is it done yet, or is still in process? I'm looking at Liz, I'm sorry. It's still in process. I've had the opportunity to listen, extremely engaging. The clinicians are engaged and moving forward utilizing that model. And the model was also utilized in Missouri with their clinical community. They are a free resource for primary care clinicians and other members of the care team, including dietitians, community health workers, et cetera. But more can be done to promote these available resources and ensure clinicians have free time. And I know some are smiling, free time. What is that? I see them, for those they're smiling back at me, I understand, to attend some of the events. Other self-paced tools, such as 12 parts micro-learning module that's available from NKF, could also be leveraged. Institutions that employ primary care clinicians or the payers that contract with them could make these tools more readily available and encourage clinicians to complete them. The literature shows that knowledge may not be enough to change rates of testing and diagnosis. More can be done to remove barriers to CKD testing in the primary care setting. The group agreed that a systems change approach is needed to optimize workflows, empower other members of the care team, and leverage clinical decision support tools such as flags, smart sets, algorithms to increase testing. Population health data tools can be used to build registries, review lab data, and risk stratify patients. That risk stratification component has come up time and time again. Given the disproportionate impact of CKD on certain populations, we also discussed focusing efforts to reach care settings enriched for CKD, such as federally qualified health centers and safety net institutions. Beyond technology, optimizing the care team to allow for care coordination, patient education, social determinant of health resources, and self-management support will ensure that more patients are reached with both tests, tools, and knowledge needed to manage a new CKD diagnosis or CKD risk factors. So what I'd like to do at this point, this was a very, very rich group in terms of, the discussions and factors. If we look at the concept of the learning collaborative, we also, on slide 38, we also discussed, this work group also discussed increasing availability of structured programs to facilitate implementation and utilization of clinical decision support tools in practices. NKF has developed a CKD learning collaborative model. We heard Liz speak to that earlier in the program, to improve routine testing for CKD and ensure that people with laboratory evidence of CKD are appropriately risk stratified and receiving guideline concordant care. Through individual clinic meetings and peer-to-peer engagement, the Learning Collaboratives provide education to help implement clinical decision support. So let's see, we are looking now in terms of what I would like to do is call up Laura, thank you. And again, and just asking in terms of the robust, this was one of the more robust of the robust conversations that were held, as you can imagine, very engaging. The recommendations that have come out of the clinical considerations work group, Laura, how do you see that making a difference in terms of what our larger mission is here? Thank you.
Like everyone else, I'd like to thank NKFI for the opportunity to participate in this. I have been a nephrology social worker for 32 years. I'm not aging myself either, but it is definitely one of those things that's very near and dear, and once you're in it and it touches your heart, you stay. I also specifically wanted to thank Amanda and Monica and Jackie for the support in this work group. Like a lot of folks have said, there's a lot of themes that we maintained that came up in different ways in each of the work groups as I'm hearing these presentations. But one of the things we looked at a little bit was there are groups out there, awareness is a huge issue, and there are disease states that have done a good job or at raising awareness. So in the diabetes world, people in the know about A1Cs and high blood pressure. You've got ranges. HIV, you know to look at viral loads and T cells, and people throughout the continuum of the disease, from providers to patients and caregivers. These numbers are sort of familiar on some level. And so what we talked about is, are there ways that we can take that set of skills and translate what those models came up with into the CKD world? We also recognized from the work of those other disease states that this is a multi-pronged, multidisciplinary process. This is not something that only a primary care provider is responsible for and can fix all by themselves in the however many minutes they get face-to-face with the patients. The patients have to be involved, the caregivers, the physicians, the nurse practitioners, and as well as the community organizations, the families. From the population health perspective, we need to be looking at community organizations, healthcare providers. This is a wide range. What we also talked about is that we need to leverage the information that's out there. We talked about having a work group or coming together with one of those numbers, one of those things that we can address, whether that's the CKD heat map, if it's a delta change in the eGFR, if it is something that the Kidney Precision Initiative comes up with, something that we can all wrap our minds around and work toward as a larger community. Technology can be beneficial and it can be challenging, as it sounds like some of our Zoom participants may have known, and we all spend time when the computer system goes down, we are lost. But there are ways to optimize that, to use those services that the technology can provide, working with our partners in the electronic health record world, the lab systems once we get them to fix their eGFR, pharmacy systems, that we need all of these folks together at the table to make a difference so we can move forward and roll out into the community of providers. Thank you.
Thank you, Laura. At this point, we should be on slide 40. And when we look at the addressing accessibility barriers, we also recognize that what gets measured, I'm going to move us ahead to slide 41, to what gets measured. Our policy, payment, and quality measures work group spoke to the importance of leveraging Illinois data and research on rates of diagnosis, disease progression, disability workforce implications, and death to tell the story of the impacts of CKD and the need for intervention. It was recommended to create a work group to develop a shared data story. I'll say it again, a shared data story. We're really focusing on having this be a data-driven initiative, creating metrics of success and monitoring, and identify positive deviants or success stories. The goal is to have a comprehensive data picture that covers all, or at least most, of lives here in Illinois. This recommendation will also demonstrate the cost and impact of CKD population health interventions for a return on investment. From these tools, the conclusions can build the business case for earlier detection and management of CKD. The dashboard will also provide an opportunity to see the impact and prevalence on social determinants of health and how the social determinants alongside with CKD to further understand the impacts of those determinants and the disparities and the opportunities for interventions to advance equity. So if we look at the leveraging policy, payment, and quality measures, and thank you, Dr. Saunders, both HEDIS and Medicare MIPS program have released new quality measures to assess guideline concurrent CKD testing in at-risk individuals. The Kidney Health Evaluation Measure for patients with diabetes evaluates the percentage of patients with diabetes who have received both eGFR and UACR testing in the past 12 months. The work group members agreed that these new quality measures will better illustrate the current gaps in CKD testing that drive low rates of CKD diagnosis, which in turn translate into poor outcomes and increased health care costs. Many payers, clinicians, and health system leaders that we have spoken to continue to view quality of care through the lens of an old measure. Medical attention based on, this was a quote from Medical Attention for Diabetic Nephropathy. The old measure does not accurately show testing rates and can give an elevated perception of testing rates, making clinicians and payers feel that they're doing a good job. The clinical considerations, the policy and pricing work group agreed that more needs to be done to increase its visibility, reach, and impact, including further education for payers and care providers on why the new measures were needed, are needed, and exploring additional data to support a financial case for early CKD testing and diagnosis. There are multiple opportunities to collaborate with the payer community to understand plan performance around this measure, identify high-performing plans that could provide models to replicate, and low-performing plans that could benefit from further resources. These payer collaborations could also include discussions around prioritization and incentives related to the measures. With proven success of 10 unique payers engaging at a virtual roundtable series discussion for the state of Missouri, there could be an opportunity, using them as an example, there could be an opportunity to convene payers and care providers to explore the steps that could be used to develop composite measures or measures set to benchmark quality CKD here in the state of Illinois. So what I'd like to do now is Dr. Milda Saunders, thank you again for serving as facilitator for the payment and quality work group. We really appreciate that, and ask your perspective based on these recommendations that came from this work group and the impact. I read the recommendations, but I know that, hey, hearing your perspective will gain additional insight for our attendees. So thank you.
Thanks. I want to thank Jackie and NKFI and my co-facilitator, Dr. Washington, and our work group, whose ideas and brilliance sort of really helped move this forward. And so one of the things that we talked about was getting everybody involved. And so not just having new requirements, which is important, and new measures, which was also important, but also having resources behind that so that we can mobilize community organizations, community hospitals, federally qualified health centers, and getting all actors involved, including EHR companies, including funders, including payers. And so the impact, we think, would not just be new measures, but also sort of new quality metrics and ultimately new, better health for our patients. And so I think that one of the things that we got from our group is that there's so many organizations and people that are already involved, and we want to give them the education and the time and the training that they need to provide all of the things that they already want to do anyway, without just having an additional ask of them, but also having sort of an additional give. And so thank you so much.
So Emily, since I'm near the stage, I'll go ahead and say the part right then. So slide number 43. We need all of you. As you can see, we truly need all of you to advance our Illinois roadmap. There are opportunities to serve as a leader of a work group or strategy, a connector, a convener, additional partners, a financial supporter of a strategy, or to work within a designated task force. We need the diverse expertise and skill sets of all stakeholders to improve kidney health outcomes through this work. If your organization or you as an individual see alignment with any of these strategies and your existing work, let's work together. I'll say it again, let's work together. Remember, a rising tide floats all boats. So what we like to look at now is, let's see, it's time for, if we go into slide 44, summit attendee feedback and engagement. We now have time to hear from all of you about these recommendations. For virtual participants, I think we may still be working through that, but for in-person participants, please line up at the nearest microphone in the room. So let's see what we want to do now. We're going to stop the screen sharing, but we want to really have a robust Q&A. So I'm going to get to start it off because I have the mic. All right. It's a great thing. So, for primary care providers, and I'm looking at Dr. Loafman sitting over there, what are some, we articulated through the work group and through this report out some of the key challenges, because we at NKFI, the collective group, we want to and we strive to, and we know we will be moving CKD up the continuum. What is it in your assessment that we can, expounding on some of these recommendations, do to make a difference? You can go here, either. All right.
Thank you, Jackie and team, and thanks everybody for the engagement in this. So I've been doing primary care in underserved Chicago for 30 years, and I think you hear the data, you see how poorly we perform in primary care on this, and it's embarrassing and it's shameful, and I agree with all that. The question is why? You know, we get into primary care specifically to prevent the kind of things that we're talking about here today, to prevent progression of disease. So, and so I think it's so helpful that this initiative doesn't just look at primary care awareness and education as though we're ignorant of the issues. But I would just frame the primary care system we have in the U.S. was not built to prevent disease. It was built to find pathology and feed it into the system, right? And so nephrologists across the country too, they're not interested in stage 1, stage 2 disease. That's not where the money is. That's not where the help is. So it's a business model that was not designed to do what we're trying to do, and we're all struggling with that. So I can tell you in a typical primary care visit, the patient has an agenda. Remember, we have about 20 minutes. The patient has an agenda. They have 1, 2, or 5 things they need to get done, some paperwork, some questions, some pain and complaints to work on. We have already a whole list of cancer screening, health screenings, depression screening, behavioral health screening, occupational safety and workforce screening, and we have all that to do. And so there's no way to get through that agenda in 20 minutes. There's just no way. It's been shown that most primary care docs spend about 2 hours after a half-day clinic session just trying to finish up that work. So if you have all-day clinic, that's another 4 hours. That's just to get done the work we have. So all I'm saying is that if just knowing better would make me do better, we would have fixed this a long time ago. That's not enough, right? So we've been struggling. So it's time to build a model that works. And I think you can't make primary care better for everybody, but this notion of risk stratification that we heard so much about here today is so important. We have to start with some patients, and we have to start with some that are going to show a return on investment to the health system in a reasonable amount of time. Primary prevention is a 5, 10, 15-year payoff that no one is willing to invest in. You know, we still want to do it. So adding SGLT2 inhibitors, things like that, but that's about $6,000 a year to the health plan costs to do that. And where's that payoff going to come? It will come someday. But so I think this initiative, I really appreciate the complexity of it, the breadth of it. It's going to take all of us working together, as you called. And I'm really hopeful that finally we can begin to empower primary care providers with the resources and tools they need to get this done.
Thank you. Thank you, Dr. Lopeman. Would like to know, are there there are none on the chat, any additional questions in the room? Oh, Dr. Casey?
Thank you, Jackie, and it's nice to meet you, Dr. Lopeman, and good to see you, Laura, from our work group. First of all, I wanted to say I just received a text from my good old friend, Dr. Steve Corbett, who regrets he couldn't be here today, but Steve and I have gone way back at Rush. And my first job as out of internal medicine residency at Rush was to work at Miles Square. Not this glass thing you see, but basically the organization on the west side of Chicago. It wasn't one of these internal medicine residents that jumped into a subspecialty fellowship. So it's near and dear to my heart, and I have a lot of interest in this. It's been a pleasure to get to know Elizabeth through some other work, and I wanted to make a few points because this is always a challenge, and I saw, forget who it was, said we need a multidimensional approach. And I might change that to we need a unified approach. And let me explain a bit, because I yesterday gave a talk to a group from the Illinois Hospital Association on what I focus on primarily, which is control of high blood pressure through the American Heart Association. I'm one of the lead co-authors of the 2017 high blood pressure guideline, and I've been working on this baby for a long time, and it fits right into the work that NKF is doing. But we need to take our target organ hats off. This is part of the problem. And focus on, the end organ hats. and focus on the target organ, which applies to not everyone with these problems, but it's the vascular system that is the unifying approach to pick your poison: diabetes, CKD, high blood pressure, et cetera. You know, lack of exercise, other factors that are non-clinical, et cetera. That doesn't solve all the problems of CKD, but it certainly puts us into a framework of having a unified approach and looking for common ground. I'd also say Elizabeth and I have been working with a group called Lab 2.0, and for those of you who don't know what that is, that's basically the pathologists who don't get in the room much, but are sitting on treasure troves of data. And as an adjunct faculty at the University of Minnesota Institute for Healthcare Informatics, it seems as though one thing we've left out is your favorite new topic, AI. If you combine that with informatics, data science, and machine learning, there's an enormous opportunity here. It isn't figured out yet, to look at data that's just sitting there. And the last thing I would say is we have to hearken back to Monica Fox's wonder that had she felt that she could be more empowered, perhaps maybe more engaged, try to figure it out on her own, she would have done that a long time ago and maybe helped herself. And I think one of the things we didn't talk about is how do we put the patient in the middle? The average patient who may have 5 things going on, right? And that relates to what I talked about with my iron triangle. First of all, having a good, and not necessarily in this order, having a trusting relationship with the individual at risk, so to speak, to even talk about social drivers of health as one example. And then sitting down and letting the patient drive the train. I'm sure you're with me, Monica, about what's best for me now, given that I got these 10 other things to figure out from a shared decision-making standpoint. And I can tell you right now that's not going to be done by primary care. It's got to be done by a new team. It can exist on top of primary care, but it won't occur if we just put this in the room. I think Dr. Loafman probably would agree with me. And there are models out there in other regards for high blood pressure. For example, one I'm working on with Mass General, who has actually shown that within 4 months, they can take both LDL cholesterol and blood pressure and get blood pressure down to 120 and LDL cholesterol below 70 by having a team-based approach and putting it back to primary care. So I think there are a lot of opportunities to look at how we change, and it's going to be different in every environment, how we change the structural approach to this. So thank you for letting me go on.
Thank you very much. Thank you, Dr. Casey. What I'd like to do now, I'd like to call Elizabeth back up, and we would like to put the commitment slide on. That's slide 45 or 46, the commitment slide. All right. And thank you all. Thank you for the opportunity to present the recommendations.
So here's where we ask for your help. That if you guys go to the Slido thing that you hopefully will already have on your phone, we really would appreciate the opportunity to hear from you how impactful this conversation was and how willing you are to work with us on advancing these recommendations. We're not asking for money. We're not asking for anything other than the opportunity to have a conversation with you after this discussion today about what next steps we could take together to potentially address the issues that we've described and advance these conversations. So if you would kindly go to your phone and start adding your reply to the various questions that are presented there, that would be fabulous. Can we bring up the correct link? I have it here, but I don't think it would be helpful. Don't think you could see it.
It's coming on the phone.
Awesome. It's on the phone, and we just want to make sure that our colleagues that are online have the opportunity to answer that as well. Yeah, I can't see it. That's the challenge. I don't have it in front of me. So I'm just going to ask, so it's showing on the phone, but not on the Zoom share screen. All right, so we have a couple of minutes left while has everyone in the room? I'm just looking to see who's still looking down. Okay, I won't see. Yeah, it's all good. All right, so far we only have 11 respondents, and I know there's more than 11 people in this room. So if you haven't had an opportunity to find it, so if you haven't had an opportunity to find it and you don't have an opportunity to respond, we have your email addresses. So we will be sending a follow-up summary of what the data has said in terms of the responses. We're up to 28, but there were over 100 people engaged online and in the room today. We really would appreciate your consideration. And again, we're not asking for money. We're just asking for an opportunity to have a conversation about how we might work together to find the resources that we need to actually begin to advance this, this conversation in Illinois. We've been very successful in the other markets where we've done this work. We've secured additional funding for learning collaboratives. We've secured funding for novel approaches to testing, including pharmacy-driven testing. So, you know, we'd love to have the conversation about how we can advance this, even if the only thing that comes out of the conversation are other suggestions for how to make that possible. So just in deference to time, I just want to just share a couple of closing remarks. I would like to start by thanking everyone who participated in this conversation today, to our co-chairs who have graciously donated many hours to facilitating this discussion. We are truly grateful. Our workgroup facilitators and participants who volunteered their time, expertise, and collective genius in a really meaningful way. We are grateful for the concrete, achievable recommendations that you put forth. I'd also like to thank the funders who made this possible. This summit is part of a much larger National Kidney Foundation strategy called the Advancing Health Equity Initiative. And so I'd like to thank AstraZeneca, Bayer, Boehringer Ingelheim, and Aurinia, who have generously contributed to making this work possible here in Illinois and in the rest of in the states where we're moving this program forward. But most of all, I'd like to thank all of you who chose to spend 2 hours with us today, and particularly those individuals on Zoom who had to tolerate the 1960s era audio that we had some bumps with beginning. We're really grateful for your interest. We're really grateful for your enthusiasm, and we look forward to working with you as we move forward. As representatives of organizations that work on behalf of the 37 million Americans who live with CKD, particularly the majority of whom who remain undiagnosed, we are truly grateful for your time, your interest, your support in making our constituents' lives better. To those of you who chose to make a commitment, and the number we are up to now is 54, we are humbled. We are truly humbled by your willingness to join this conversation with us and be a part of what I know will be substantial change and and really positive impact on the lives of many people who don't have the resources and tools that we have, and for whom kidney disease will absolutely be destructive and detrimental. So we are really humbled by your willingness to join us. As we close the discussion today, we'd like to circle back to how we got started. The question of awareness of EGFR. You know, as I mentioned earlier, there are many people, this disproportionately affects individuals who struggle in the social safety net. So I just ask you to consider before you leave this room today how your life would change if you walked into your primary care clinician's office after being there, being treated for years, to be told that suddenly your EGFR was 30 or approaching 30, and that you're now a candidate for dialysis and transplant. How would that change your life? What kind of impact would that have on your family, your finances, your vision for the future, your ability to function on a day-to-day basis, knowing that your life is now in jeopardy and you are reliant on either someone else's incredible generosity to save your life or on the challenges associated with dialysis? How would that impact you? And if that's not something that would bring you to a Snoopy happy dance, then I suggest you, again, consider how that would impact others who don't have the resources that we have, who don't have the skills in navigating the healthcare system. And I ask you to come join us to try to address that. So thank you all for everything you've done. This has been fabulous.